Thanks so much, Sandra, and thank you, Angela, for that presentation. So my name is Tracey Cole, and I'm a nurse by background with 30 years experience in cancer and palliative care nursing, both in the hospital environment, but also in the community, as I was a community specialist palliative care nurse for many years in South London. I was seconded to the North Thames Genomic Medicine Service in September 2022 as part of a Darcy Clinical Leadership Fellowship Programme. And for the last 6 months, I've been the North Thames Genomic Medicine Services Cancer Genomics Education and Training Project Lead, just because of the learning from that Darcy Fellowship in relation to the need to improve genomic literacy. I first became aware of the term genomics and the genomic medicine service about 2 years ago in my role as lead lung cancer nurse specialist at UCLH. I was curious to know about molecular testing pathway for my patients, which is essential to undertake in lung cancer patients, as we've just heard, irrespective of whether they're ever smokers or not, in order to guide first-line treatment options. I'd not really heard of the term genomics, didn't really understand the term, was hearing various terms in the MDT that there was no time really to go into or discuss, and therefore my Darcy Fellowship incorporated improving genomic literacy in the cancer community. I realised I wasn't alone in not really understanding molecular testing pathways, but also how genomics was relevant in my practice. And that's in spite of being in cancer care for 30 years. This is just, you're seeing now a poster that was my last day poster just on that fellowship of the outputs of that fellowship. So originally when I was first interested in the genomics unit, I was really curious to find out why it took over 4 to 6 weeks sometimes for patients, and sometimes longer, to have their molecular testing. I was able to learn more about the pathology testing pathway, if you just heard from Angela, but I also was very interested in the term somatic mutation, because obviously that was something that I actually hadn't really distinguished between, for lung cancer patients. Oncogenic-driven lung cancer is a term that you will increasingly hear. It's also called never smoker lung cancer or lung cancer in never smokers, just because it is a cancer that occurs more frequently in, as you've heard, younger never smoker patients. However, sadly, they often present with late stage disease. I'd like to introduce you to Dania Shoap, who's one of our North Thames Genomic Medicine GP leads, who I've been working with recently to try and look into improving genomic literacy within the primary care field. Are you there, Dania?
I am. Thank you so much, Tracey. Hi, everybody. I'm Dania. I was introduced to genomic medicine, and what really got to me was one of my colleagues, Dr. Anwar Khan. Just a conversation started with saying, how is genomics important in primary care? And what do we know about it as GPs? And that got me thinking, and that's what actually inspired me to take on this role. Having taken on this role and understanding from sitting in the primary care seat, looking at patients, looking at what the difficulties are and the frustrations with patients understanding, getting an understanding not only for patients, but for colleagues as well, is very, very important. So, and I've been fortunate enough to be working with Tracey and all the colleagues of genomic medicine who have actually helped, and we're trying to come up with a way to streamline the processes, basically, in the end of the day, all of us are here to try and make our patient's journey better. And the patient's journey does start from primary care. So how do we make the process from primary care to secondary and tertiary care all streamlined? So they do have help and they are supported during this process. I'll hand back to Tracey now. Yeah.
Thanks, Dania. So I've had the privilege of working with these two ladies I'm about to introduce for a few years now. Both of these ladies are patients and they have oncogenic-driven lung cancer. And they are also chairpeople of their respective charities. And I'm really appreciative of their input today. So I'd like to introduce Angela Terry, who is the chair of EGFR+ive UK. EGFR being one of the most common oncogenic-driven lung cancers. And I'd also like to introduce Debra Montague, who is the chair of ALK+ve UK, which is another oncogenic-driven lung cancer patient advocacy group. Ladies, I just want to say thank you so much for your time today to come and tell your stories. We know that actually these sessions can be really helpful in hearing the patient experience, and certainly professionals can learn from hearing your experience, so thank you. So turning to Debra first, I've just got a first question to just say, can you just tell us a little bit about your diagnostic journey, Debra, and your illness?
Yes, and thank you very much for the opportunity, Tracy, to share it today. So I originally had a cough for several months, just annoying, and it was my work colleagues that made me make the GP appointment because I was actually just getting on their nerves. So I think I would have waited even longer if the truth be known. I was in a busy job and couldn't really find the time, and it was only an annoying cough. GP did a blood test and sent me for an x-ray because she didn't think it was adult onset asthma and couldn't come up with anything else because I didn't have a chest infection. So the results came back and they were unremarkable and didn't show anything. My GP very kindly reassured me that I didn't have lung cancer. And because the results of the x-ray and blood tests weren't conclusive in anything, didn't show anything, then we used my private health insurance to access respiratory consultant quite quickly. So I was one of the fortunate ones at that time. So I was seen by a respiratory consultant. He did the same x-ray and blood test, and I went back to see him, and he seemed surprised that he got the same results as the GP tests. There we are. But he also reassured me that I didn't have lung cancer because I wasn't a smoker. So because he couldn't find anything, they sent me off for a CT scan. And I remember going back to see him on the 6th of October, 2016. And at 7 p.m. that night, he told me that I did have lung cancer. So, so that was the route to my diagnosis.
Thanks, Debra. And Angela, do you want to be able to tell us a bit about your diagnostic journey as well?
Yeah, of course I will. Thank you very much, Tracy. My diagnosis is a little bit odd. I was skiing in Austria. I had a fall. Then I had an x-ray in A&E, and I was told there was something suspicious in my lung, and not to worry about it, but come back next day. Went back next day, and they kindly did a CT scan. And really within 18 hours, I knew I had lung cancer. At that point, I was in Austria with my family, and we went to Vienna. I saw a thoracic surgeon, and within 8 days of my fall, I'd had a lung resection. I stayed in Vienna for another 10 days and then came back to the UK. And it must have been really odd for the GP because I walked in, I had no symptoms, I was fit, I was a never smoker, I had no sign at all that anything was wrong. And I saw a very young GP and he was absolutely wonderful. I had a folder under my arm with all my diagnostics written originally in German and translated into English. And he very efficiently referred me to the hospital, and upon additional investigations in the hospital, it was found that I wasn't stage 1B and curable. I was actually stage 4 because they found another tumour on my back. So mine is a kind of unusual story in that I arrived at the GPs with my diagnosis. I even knew I was EGFR positive when I got back to the UK. More common perhaps for our members, both Deb's group and ours, is that many face a delay in diagnosis, partly because we don't look like lung cancer patients. We're fit, we're young, we're active, we've never smoked. So GPs don't necessarily think lung cancer when we arrive. A more common story would be one of my colleagues, 49 years old, female, active, working, non-smoker, had a shoulder pain she thought was due to overstretching in yoga. Went to the GP, painkillers, sent to a physio, that didn't work, came back, chest infection perhaps, no it wasn't, ended up in hospital. They thought it was TB, and eventually an X-ray found a tumour in her lung. So she waited 9 months, by which time she was stage 4 with brain metastases. And I'm really sorry to say that is so common for oncogene-driven patients. We just don't present and we just don't look like the average lung cancer patient.
Thanks so much, Angela. And I've just popped in the chat there a link to Ginny's story that actually I would really absolutely suggest you have a look at. It's actually a really good learning resource that's actually been put together. So, right, next question. What has been your experience, Deborah, of living with a stage 4 oncogenic-driven lung cancer for the last 8 years nearly, isn't it?
It is, yes. This October will be 8 years. So I'm kind of working on, I'm going to make 8. So, well, it's, yeah, it's been interesting. So it's not what I expected. Once I was on treatment, the cough cleared up within 2 weeks maximum. So the most difficult bit has been dealing with the side effects of the different treatments, because they don't come without side effects. So yeah, so they tend to wax and wane, but on the whole, fine. I returned to exercise class. I've been on various holidays. I've done a tough mudder. I've abseiled, thrown myself out of aeroplanes. I don't know why, but it's been generally fine. The worst part, I suppose, is whenever you meet someone and you tell them you have stage 4 lung cancer, you've got ALK+ lung cancer, and they say, "Oh, I didn't know you smoked," and so you have to do the whole, "No, I haven't. I've never smoked. You actually only need a pair of lungs to get lung cancer," but that's been my experience with GPs as well. So whenever I have been unwell, I have taken, I've gone to the GP, and in every single instance, unfortunately, I have to say, they've said to me, "Oh, have you stopped smoking now?" And I then have to get my soapbox out. I feel it's my duty to educate then. So I would have expected things to have moved on in 7 years, but unfortunately they don't seem to have. I had unfortunately the need to go to my GP practice recently, and it was a new one, and I came across the same question again. So yeah, but on the whole, living with is relatively easygoing, and yeah, I've had a great life for 7.5 years so far. Yeah.
Thanks, Deborah. And Angela, what's your experience been of living with a stage 4 lung cancer?
I'm very similar, and in fact, I find when I say to people, I've got lung cancer, I often almost apologize by saying I've got lung cancer, but I never smoked. because I do that because I know they're going to ask me, or they're going to think I smoked. So that's the thing we carry. I mean, I'm stage 4. I'm fit, active, low burden of disease. It's my 5th anniversary from diagnosis last week. So Deb and I are definitely bashing through the statistics, which is great. But that's one of the things that reminds me that I'm ill is the monitoring. Every 3 months, I go in for a brain MRI, a CT scan, bloods, blah, blah, blah. And every 3 months, I'm in the hospital and I'm faced with, oh my goodness, I have got lung cancer. I have got an incurable disease. But apart from that, because the medication is so fantastic, it's a daily tablet. I can almost forget I've got lung cancer at times. And that's really good. But something that concerns me greatly is I travel to a hospital, which is 2 hours away from where I live, and they are fantastic. And all of my relationship is with them. I have no relationship at all with my local GP. They have never contacted me. If I have a problem, I wouldn't dream of going to my GP. I go straight to my cancer nurse specialist. This concerns me because at some point my cancer will mutate and I will come back into local care system. And I'm leaving this hospital where I have a really deep relationship with some of the people there, having been there for 5 years. And I'm walking into a situation where I do not know the people at all, and they don't know me. And they haven't met me when I've been well. They're seeing me when I'm now really poorly and a lung cancer patient. And I think that's going to be really hard. And it saddens me that I don't have a local connection.
Oh, thank you, Angela. I know that we've actually talked about that before. I've actually just put in the chat as well the See Through the Symptoms campaign that actually both Angela and Deborah have been very key in actually that campaign. So again, if you could actually have a look at that, that link, that would be great. So I'm just going to hand over to Dania now.
Thank you very much. An eye-opener for all my primary care colleagues that are with us. I mean, having a patient or having somebody say that they're really scared that they don't have a relationship with their GP, one of our most vulnerable groups, is now coming to a point which is worrying. So if I were to ask Tracey, Debra, both of you, how do you think the primary care and tertiary care could work together to improve your experience? I mean, what do you think we could do differently?
I think it would be great if my GP, because I've recently moved, so I've got a new one, actually wanted to make contact with my oncologist to learn about me, to keep me alive for as long as possible, because I'm not old, and I'd like to be here for a lot longer, as much as I can, and it does require both primary care and secondary care. It would be great to think that because we're so rare, quite rare, the oncogene-driven lung cancers, that GPs would be interested in us as a different case, and that they would maybe take the time to contact the oncologist just to find out if there's anything they need to be aware of. Then I think that would be fantastic. And at least then, as Angela says, you know, then we'd have, it would be less scary when the time comes and our treatments aren't working, that we need to be transferred to primary care. And then it would, you know, the handover would be seamless, and we would know someone, which would be fantastic, and have a familiar face. It's a scary place to be, and yeah, the thought that there's no one in primary care that understands me and knows what, one, I'm capable of now, and two, what I, you know, how I would be best managed going forward. That's what I think would be fantastic, to think that someone had taken the trouble to find out.
Thanks, Deborah. Do you want to just chip in, Angela?
Yeah, it's so important. Someone's taken the trouble. Someone cares about me, because I feel very alone. If I suddenly collapse today, I've no link with the hospital. I've no link. I don't even know which hospital I would be taken to. I'm very aware also that my GP gets copies of all my letters. So every 3 months there's a letter pops in about me. I don't know who reads it. Nothing ever comes of it. And what I would love is there's cancer care reviews now for newly diagnosed cancer patients. Now, I wouldn't get one of those because I'm 5 years in, but I would love to have a conversation about that. And these forms, they aren't just ticking boxes, they're the basis of a relationship. It gives us a structure to say hello, and it gives us a structure which says to me, you've been cared enough to take 10, 15 minutes to talk to me, and I look forward to seeing you again. Even someone phoning me once a year, and it doesn't have to be the GP, it could be a nurse, it could be the lovely receptionist, whoever, saying, how are you, would make a huge difference to me. And I guess, as Deborah said, your bottom line is, wouldn't it be great if primary and secondary care were more joined up, so people like us didn't feel held in a limbo land where we have to find our way through it?
Thanks, Angela. So I'm very aware that there are a couple of hands up and some comments in the chat, and we will get to you. But I think what I would like to say, I want to obviously just give a little bit of a different perspective as well. I, as a hospital-based lung cancer nurse specialist, because I've found with oncogenic-driven lung cancer patients, there is this fundamental issue around trust, which affects these patients in particular. Because if there has been a delay in their diagnosis for whatever reason, waiting for molecular testing adds to that mistrust if patients aren't given the right information. So the whole issue of somatic testing for this patient population is really important. And sometimes, as a hospital CNS, if patients are told that their test has failed, they will automatically or understandably think, oh my goodness, you know, somebody's done something else wrong. And I think we really need to be careful of the nomenclature that we use as professionals when we're talking about genomic literacy and molecular testing. So I think, you know, that actually is something that as professionals we need to work on. I have experience of speaking to patients who've been told that they've had a genetic test, and like you heard it from Angela, they actually think, they hear the word genetic and think they've inherited it. So it's actually really important that nurses know the difference between, and medics know the difference between somatic testing, which is the diagnostic molecular pathology testing, and the germline testing. So patients also need to know that there's a risk of rebiopsy. And so I've actually, from my outputs of my fellowship, is that actually we really need to be giving patients realistic turnaround times about their molecular results. We actually need to explain to patients the importance of the testing in relation to this precision medicine. Obviously, we often as CNSs and as primary care physicians hold patient symptoms while they're going through the diagnostic pathway. And it's really important that we communicate, for example, if somebody is diagnosed with brain mets, they may be on steroids while waiting for their molecular test results. So, you know, that communication with primary care is really essential. And also, I think lastly, just having a contact number. And working, somebody who has worked in community palliative care as a hospital lead for a lung cancer service, I'm always, what does the GP know? I'm happy to pick up the phone and actually have that communication about where patients are at. And I think certainly, just as a flag, I know people have put about this cancer care review. I didn't know about that until I actually was a member of this cancer primary care community of practice. I didn't know as a hospital nurse. And then when I was talking to Deborah and Angela, who I've known for a while, they didn't know that that was something that actually was at. So it's about spreading the word and having forums like this to be able to improve communication across boundaries. So I'll get off my soapbox there.
Tracey, I think there's a hand up and there's a few kind of comments in the chat. So are you happy to move on to questions now?
Yep, that's fine.
Well,
Do you, I'm just going to say, so who wants to go first, Anwar or Lena?
I think Lena's first.
I'll do it, Tracey. But basically two things. So I've been following up a patient of mine who's been diagnosed with rhabdomyosarcoma. And I said to him when I sent him in, by the way, I didn't diagnose it straight off. So when the diagnosis came back, I said to him, I'm only lending you to the hospital. You're my responsibility. And I think it's important to do that. And the second thing I say to the patients is, through the letters and your updates to me, I learn about rhabdomyosarcoma. I last read about it when I was a medical student 42 years ago. So I think there is something about patients feeling empowered to book with their GPs, to update them, even in this very specialist area. Why? Because we provide the holistic care, and there'll be other needs, like, well, not in Angela's and Deborah's case, but things like social prescribers and other bits. So I would please don't, should we say, not involve us, because we also learn through the patient's experience. And actually, it's a longitudinal relationship that attracts me to primary care. By the way, I used to be a geneticist.
Thanks, Anwar. Lena.
Yeah, hello everybody, and thank you, Angela, and all the other patient experience stories there. It's really powerful to hear for us health professionals who are working what actually is needed. My role, I'm a nurse facilitator, and I work between our local hospital and all the GP practices in my ICP. And my role is to increase the training and the awareness of the cancer care reviews. Cancer care reviews have been in the sort of expected from the primary care already many years, but it's in the last few years got more emphasis in terms of not just being a quick tick box thing for the primary care. It's more sort of holistic, wholesome review and offer of support. And I totally agree with Angela, and getting feedback all the time from patients that what patients want from primary care is not the oncology expertise, which they already get from the secondary care, but it's the offer of the support, saying that we're here for you. It can be something very practical, like, for example, if somebody needs a blood test before their chemo going to hospital, the care coordinator can help to book these appointments so that the cancer patient doesn't have to wait 40 minutes in a reception queue in the morning to book an appointment. It's signposting for mental health and emotional support, financial support, social prescribing, but also just things like medication review. End of treatment summaries from the secondary care are extremely important for the primary care colleagues, because that often tells the most about the newest treatments, their side effects. The GPs can't keep up with everything, because like in a recent oncology study date, they said there's been more than 12 new breast cancer treatments, for example, with all various new side effects associated. So the sort of the communication between different sectors is really important for the continuity of the care. But I'm happy to say that the cancer care is definitely establishing itself more in a primary care. It's not seen anymore just by a secondary care expertise. It's a long-term condition, a bit like diabetes and heart disease, and it has to be looked after holistically in primary care. Thank you.
Thank you, Lena. Are there any other questions? I note that there's actually a comment in the chat just from Jenny about raising awareness and the role of patient advocacy groups, which obviously both Deborah and Angela are here representing. What I would add to that, though, is interestingly, when we did a review of how patients found these patient advocacy and support groups, they weren't signposted by professionals, including CNSs and professionals within the hospital environment who were looking after them. Patients like Angela and Debra actually are quite motivated to find their own sources of support. However, we need to be able to do our bit and signpost them as well. Dania, did you have anything else that you wanted to say?
So I'm hearing Angela's and Debra's story and coming to the point that they weren't aware of cancer care reviews, not having the continuity with their GPs and things. Maybe also one of the powerful ways is, if you don't think, or you haven't had a cancer care review, or there isn't awareness, every practice nearly has a patient participation group, a PPG. Maybe raise your voice through them, because they do come and meet us in GP land, and they do raise what things are there. So come in and speak to us, and it's just like working together. Everyone is busy, but you're our most vulnerable group, and we would like to know how we can provide better service and improve your journey. So just coming to that bit, if how did everybody feel about it? What were everybody's thoughts on taking home from this session? If you would like to just add a comment or something, if there was one take-home message we would take from today's session, what would that be for us? What would we change?
People can use the chat, can't they, to just pop that in there now?
Yes, please. I mean, for me, is that, yeah, just exactly what you said, Anwar. It's continuity of care is so important. And I raised it with my PPG saying, can they get the message out for cancer care reviews and everything? If there is anything that I would like more support with, I got that message out, because coming from secondary care, it would be quite nice. It comes from primary care as well. Thank you.
I think that's, unless there are any other questions, thanks so much, Dania. I'm just going to hand back to Sandra. Thank you for the opportunity to speak today about genomics, and especially in regard to oncogenic-driven lung cancer and the somatic molecular testing. So thank you, everybody, and thank you for your participation and for your contributions.
Thank you, Tracey, and thank you to all our participants today. I've just got a few words about our community of practice. But before I move on, Tracey, was there another webinar that you want to mention at this point, or are we going to share the comms later on? Yes,
so I will. Yes, we have, in terms of primary care and cancer, it's Dania and I have been trying to, and Anwar have been trying to make understandable sessions that are very friendly forums, if you like. And on the 22nd of February, we have a primary care and breast cancer session that actually would be really useful for GPs, ANPs to attend. It's very much focusing around the difference between that inherited cancers and the blood tests that are happening and germline mainstreaming, etc., versus when, for example, as you heard about direct-to-consumer testing, what to do if that happens. And in that session will be launched the North Thames new genetics referral form. So that is on the 22nd of February. And if you want to attend that, just go onto our website, which I've put on there, and you can register through that, I think. But if not, just pop your email in and in the chat, and we will make sure that you actually get an invite to that session.